Hey doctors and future doctors, I'm Dr. T.S. Hazaria and today we will talk about Cushing's syndrome. So Cushing's syndrome is a rare condition where the body exposed to high levels of cortisol hormone due to hyperfunctioning of the adrenal gland. So today we will understand the topic in 6 steps, right from the introduction, causes, pathophysiology, signs and symptoms, diagnosis, and lastly management. So let's talk about the introduction. So Cushing's syndrome occurs when your body is exposed to high levels of the hormone cortisol for a long time. Cushing's syndrome, sometimes also called hypercortisolism, may be caused by the use of oral corticosteroid medication use. This can also occur when your body makes excess of cortisol on its own. And when the pituitary gland releases too much of ACTH hormone, this condition is known as Cushing's disease. So Cushing's disease is basically a form of Cushing's syndrome. So on the basis of this, we can categorize the Cushing's syndrome into 3 categories: primary, secondary, and tertiary Cushing's syndrome. Primary Cushing's syndrome is because of the autonomous overproduction of the cortisol hormone by the adrenal gland, and that may be because of the adrenal adenoma and adrenal carcinomas. Secondary Cushing's syndrome, when there is the increased production of ACTH either by the pituitary microadenoma, that is Cushing's disease, or by the ectopic sources like small cell lung carcinoma. When we talk about the tertiary Cushing's syndrome, that is because of the increased CRS production by the hypothalamus itself. So after introduction, we will talk about the causes of Cushing's syndrome. So when it comes to causes of Cushing's syndrome, we can divide them into 2 categories. One is exogenous and the second one is endogenous. In exogenous causes, iatrogenic steroid use is the most common cause of Cushing's syndrome. When we talk about endogenous causes, then less than 10 mm pituitary microadenoma is the most common cause. The other endogenous causes of Cushing's syndrome are adrenal adenoma, carcinoids of bronchus, that is small cell variant, medullary thyroid carcinoma, pheochromocytoma. Please take a note that when the question is like what is the most common cause of Cushing's syndrome, the answer is iatrogenic steroid use. And when the question is what is the most common endogenous cause, yes, then the answer is pituitary microadenoma. So after causes, we will talk about the pathophysiology of Cushing's syndrome. As we know that paraventricular nucleus in hypothalamus secretes CRH hormone, and that stimulates the anterior pituitary gland to release ACTH. These ACTH travel via the bloodstream and reach to adrenal gland and stimulate the adrenal gland to release cortisol hormone. And excess of cortisol hormones gives the negative feedback to the hypothalamus and modulate the CRS release. So generally what cortisol does in the body, as we know that cortisol decrease the bone formation, decrease immune function, increase gluconeogenesis and lipolysis, also regulate the blood pressure, and most importantly act as an anti-inflammatory agent, right? So with this we can imagine when there is excess of cortisol in the body, what kind of worse outcomes we can have. So after pathophysiology, we will talk about signs and symptoms of Cushing's syndrome. Signs and symptoms of Cushing's syndrome can be memorized with a very beautiful mnemonic, Cushing a poem. So here C stands for central obesity, U for unusual bruising, S for stray on skin, H for hypertension, hirsutism and hypercortisolism, I for iatrogenic steroid use, N for sodium and fluid retention, G for gynecomastia, glucose intolerance, A for amenorrhea and acne, P for psychosis and plethora, O for osteoporosis, E for edema and ECG abnormalities, M for moon phasie and proximal myopathy. Please also take a note that hypokalemia and metabolic alkalosis are prominent in the Cushing's syndrome patients. So other less common signs and symptoms of Cushing's syndrome are like weight gain, slow wound healing, increased risk of infections, fatigue, depression, anxiety, irritability, and loss of libido. This is how one Cushing's syndrome patient looks like patient having the stretch marks on skin, thinning of skin, bruising, slow wound healing, and acne. So after signs and symptoms of Cushing's syndrome, we will talk about the diagnosis of Cushing's syndrome. When a patient presents to your clinic with the clinical signs and symptoms of Cushing's syndrome like plethora, moon phasie, buffalo hump, then we have to perform the initial screening test and we need to confirm the diagnosis with the confirmatory test. For the initial screening test, generally we perform 24-hour urinary free cortisol test, 1 mg overnight dexamethasone test, and late night salivary cortisol measurement test. Sometimes we need to perform more than one test and we need to repeat the testing for the appropriate diagnosis. When the patient having Cushing's symptoms and also the initial screening tests are positive, in that case we have to validate the cause and source of Cushing's syndrome, and we need to go for the confirmatory test. Generally, we perform plasma ACTH concentration test, high dose dexamethasone suppression test, CRH stimulation test, and petrosal venous sinus sampling test. Since the diagnosis of Cushing's syndrome is not easy, so in that case we approach the patient in 4 easy steps. So in first step we do 24-hour urinary free cortisol test or 1 mg overnight dexamethasone test, any one of the two. So when we do 24-hour urinary free cortisol test and the cortisol level is 3.5 to 45 microgram in a day, when we do 1 mg overnight dexamethasone test and the cortisol level is less than 2 microgram, yes, the patient is normal, though is having the Cushing's symptoms but is not having Cushing's syndrome. When the cortisol level is abnormal, then we have to repeat the test and we have to do more tests. So in step 2, we repeat the 2 mg dexamethasone suppression test and 24-hour urinary free cortisol test. So here we use 2 mg of dexamethasone instead of 1 mg. So if the patient is normal, then yes, we can say that in the previously test the result was positive, because that was the false positive. That may be because of depression, anxiety, and might be patient using some kind of estrogen. And when the cortisol level is abnormal, then yes, we can say patient is having Cushing's and we have to establish the diagnosis. When the screening tests are positive and patient also having the Cushing's symptoms, then we have to do the confirmatory test, generally perform plasma ACTH concentration test. Here if the plasma ACTH concentration is decreased, yes, then the source of ACTH is adrenal tumor, right? Because as we know that excess of cortisol gives the negative feedback mechanism and that suppresses the plasma ACTH level. When it's increased, then yes, the source is either pituitary or ectopic source. So in that case, we need to find which one is the source, either pituitary or ectopic. So for that, we generally do high dose dexamethasone suppression test and we give 8 mg to the patient. Still, if the cortisol level is suppressed, then yes, the source is pituitary, and in this the condition is known as Cushing's disease, not Cushing's syndrome. When the cortisol is not suppressed, then yes, the source is ectopic source, and we know that ectopic sources do not follow and do not obey the negative feedback mechanism phenomenon. So after diagnosis, we will talk about the treatment of Cushing's syndrome. There are various options are available. Generally, doctors do transsphenoidal surgery for ACTH secreting pituitary microadenomas. When the surgical cure is not achieved, in that case, radiation therapy is also performed by the doctors. For adrenal adenoma and carcinomas, surgical excision is performed. Mitoten is also given for the metastatic and unresectable adrenal carcinomas, and debulking of lung carcinoma and carcinoid tumors are performed, and that result in remission of ectopic Cushing's syndrome. Bilateral total adrenalectomy is also performed to control the hypercortisolism. Please take a note that bilateral total adrenalectomy is the definitive treatment of Cushing's syndrome. In the cases when the source of ACTH cannot be resected, in that case we go for the medical management and prescribe the patient generally ketoconazole, miterapone, and mitoten. So thank you so much for listening, and please don't forget to subscribe my channel for the future videos.